thank you. And today I'm going to talking about what we know about the epidemiology of GPP. So as this is my conflict of interest. Okay, so I will speak three parts. First of all, I'd like to speak about the GPP disease background. So what is actually the GPP? More than 100 years ago, von Zubosch first published an article writing GPP in 1910, so 100 years ago, more than. At that time, he writing about skin inflammation, thickening, and the needle-sized pustula all over the body, dark reds, and the swollen skin almost completely detached, and usually high fever, and the patient had 9 acute attacks in 10 years. It's very severe cases. And first, I'd like to talk about the definition of GPP in 2017 Europe consensus. So generalized pustular psoriasis is defined as a primarily sterile and microscopically visible pustulas on non-aggrieved skin. So the interleukin 36 pathway is central to the pathogenesis of disease. And there are also different kind of symptoms. First, skin symptoms, the pain, pusturitis, scaling, erythema, drying, and the burning sensation. In addition, there's also systematic symptoms like fever, edema, physical discomfort, and joint pain, and asthenia, and headache, and leukocytosis. There's at least 6 diagnostic elements must be considered, like the skin systematic symptoms, differential diagnosis, complications, medical history, laboratory evaluations, and histopathology. And this is important element we must consider for the diagnosis. And there's also assessments. The generalized pustular psoriasis area and severity index, we say GP PASI, and is modified from PASI in psoriasis. We also use this method, and consists of erythema, scaling, and pustula combined with the percent body surface area, and is scored from 0 to 72. And the generalized pustular psoriasis physician global assessment we called GPPGA assessment, severity of the pustulas, erythema, and GPP lesion grade with scores of 0 to 4. So there are some more assessment tools. So, but first two we are very familiar is GP PASI and the GPPGA, and also there's very common assessment used in Japan, and so on. So there's many others. And now we come to GPP disease flow modulation. So there's a lot of epidemiology survey in the world, and they're various. And the challenges we face is the following 5 elements. Factors influencing prevalence survey. There are misdiagnosis is the first point. And then lack of awareness among the common people. And also non-standardized methodologies. And people use different ways, but now people use something very, very easily understand, and there's trends to use standardized method. And the fourth one is low patient numbers, and this is rare disease. And but now people pay more and more attention on this. And the last one is different data resources. And this is, nowadays the big data resources are commonly used, and we have more and more accurate than ever before. So what is the current epidemiological status of GPP? There's four elements must be considered. First is age, gender, genes, and countries. So GPP can present at any age, including as juvenile GPP. The majority of cases presented in the fifth decade, and the mean age at diagnosis have been reported as 45.6 to 50 years at this range. And the female may be diagnosed earlier. Mean age is around 39.4 years than males. And the data may vary by the different regions. There may be a female preponderance in GPP. A study in 102 patients from Malaysia reported that the ratio of 2 to 1 and in females versus males. A study of 74 patients in US reported at this ratio. And a study over 300 patients in Japan, 51.5 were female. However, the extent of this varies by geographical region and between ethnicities. Genes. The frequency of interleukin 36 RN variants show the regional difference. For example, in Malaysia, patients, this number is around 28.8%. Then in Europe, people, this accounts for 34.7%. And present data support that the Han Chinese patients account for almost 46.8 to 60.5%. It seems it's the highest around the patient in China. So now comes Chinese data. The crude prevalence of GPP in 2016 was 1.4%, not percent, per 100,000 people. And this is very accurate. I think the first reported in China. And prevalence is higher in male than those in female. And in the terms of age distribution, the prevalence show that bimodal distribution, with the first peak occurring around 0 to 3 years. And the highest prevalence is another peak is around 30 to 39 age group. Similarly, similar distribution was observed for prevalence in different age groups of male and female. So this is we call the biomodule on this, and this is published in last year in our National Dermatology Congress, and this is based on the medical influence calculation. And this is first reported in China. And there's other countries like countries in France, and they have the incidence and the prevalence of GPP were estimated around 0.6 to 1.7 per million person year, respectively. And in country Japan, from 2015 to 2018, the prevalence rate of GPP in Japan was 30 per 100,000. And in Northern Europe, country like Sweden, the annual prevalence in 2015 was estimated at 1.53 GPP cases per 100,000. In a country in Brazil, the GPP prevalence in Brazil is to be between 0.7 to 0.9 per 100,000. And also in Germany, estimated prevalence of GPP is around 1.4 per million. And in South Korea, it's around 8, it's a really large number, 89 to 124 per million. And in USA, it's around 90 per million. So different cases, different countries varies in this GPP epidemiology study. So last we come to GPP burden of the disease. And the economic burden of GPP patients, and this is American one, this is French one, and the data-based study. GPP-related therapy may threaten the patient's life, and life-threatening complications include sepsis, renal, hepatic, respiratory, and heart failure. But what is important is the immediate cause of death is GPP or related therapy. So particularly as a systematic corticosteroid. And sepsis is a common cause of death. And here's the country mortality in different year period. So we conclude, GPP is an autoinflammatory disease, and interleukin-36 signaling pathway play an important role in GPP development. The challenges remain in the epidemiology of GPP, and understanding the available data contributes to our understanding of the disease. And lastly, the GPP places a heavy burden on our patient. And I think I conclude this for today, and thank you.